Greetings, this is Zahir Nali from the Solve ME CFS Initiative, welcoming you to our 2017 webinar series. We have a very special guest with us today. We have Dr. Peter Rowe, who is a leading expert in the ME CFS field and also a member of our Research Advisory Council. Dr. Rowe will be doing something exciting, as Dr. Rowe always does. He will be giving us today a practical primer, a clinical approach to ME CFS in adolescents and young adults. Just very briefly about Dr. Rowe, who does not need an introduction to this audience. Dr. Rowe is currently the Sunshine Natural Wellbeing Foundation Professor of Chronic Fatigue and Related Disorders in the Department of Pediatrics at Johns Hopkins University School of Medicine. He has held several leadership positions, including being the director of the Chronic Fatigue Clinic at Johns Hopkins Children's Center. He received his medical degree from McMaster University School of Medicine in Canada and trained for his residency and fellowship at Hopkins. Dr. Rowe's clinical interests and research are focused on medical conditions characterized by chronic fatigue syndrome. His work first described an association between neurally mediated hypotension or postural tachycardia, which are two common and treatable circulatory disorders, and chronic fatigue syndrome. The research from Dr. Rowe's program has also brought to light several novel contributions that Dr. Rowe will be touching on in this talk as well. His research has been funded by the National Institutes of Health, the U.S. Department of Defense, the Solve ME CFS Initiative, and several other smaller foundations, as well as private philanthropy. He has directed the Chronic Fatigue Clinic at the Children's Center since 1996. And finally, Dr. Rowe has published hundreds of original research work, review articles, case reports, proceedings, white papers, briefs, published curricula, letters, correspondences, book chapters, and monographs. And we will need the full hour to highlight these, but we will not do that because we are very excited to hear from Dr. Rowe. And towards the end, Dr. Rowe will also tell us about a primer that he has finished co-authoring with a group of international leaders, really, that will be published very soon. So, Dr. Rowe, without further ado, thank you for doing this. We are thrilled to hear from you. The floor is yours.
Great. Thank you very much, Zahir, and welcome, everyone. As we were thinking about what to do with today's session, we were quite aware of the gap that exists between the number of people who are affected by ME CFS and the availability of specialist practitioners who are familiar enough with the evaluation and management of the illness to help out. And so we thought we would try to bridge that gap, at least for the adolescent and young adult population, with today's webinar, hoping that this will be a resource that's available online for physicians, for nurse practitioners, for families to look at afterwards and try and improve the number of people who are covered by good care. My title is This Clinical Approach to ME CFS in Adolescents and Young Adults. I have no relevant financial disclosures, but I will be discussing some unapproved commercial products in the presentation, mainly because there have been very few studies of medications for pediatric CFS. So the objectives are to discuss the main features that differentiate this illness from other conditions, and with a focus on how physicians will work through patients presenting with chronic fatigue. We'll describe the clinical features and the investigation of pediatric ME CFS, and we'll discuss some effective management strategies for addressing symptoms in the illness. Let's start in with the definition of CFS. The fatigue criteria really comes from the Fukuda definition that was published back in 1994. This is the one most commonly used in research settings, and to have the fatigue in CFS needs to be at least 6 months, has to be of new or definite onset. In other words, it can't be there from early childhood and lifelong. It also can't be the result of too much exertion, that is, such as you'd get from working, say, 3 jobs or doing 2 or 3 sports in adolescence at a very high level. It is not substantially alleviated by rest, and it has to result in some kind of substantial reduction in what that person was able to do in the past. In addition to the fatigue criteria, you need 4 of these 8 symptom criteria. One is unrefreshing sleep. No matter how much sleep people have gotten, they awaken feeling exhausted. The second is post-exertional malaise, an exaggeration of all of the symptoms of the CFS, not just fatigue, that lasts more than 24 hours. Then there's self-reported impairment in short-term memory and concentration, and for clinicians this looks as if the patient with CFS suddenly acquired attention deficit disorder without the hyperactivity. Very similar range of symptoms. The other 5 are pain symptoms: sore throat, tender glands, muscle pain, joint pain, and headaches. But over the 20-some years since these criteria have been available, there have been some problems that have emerged. One is that there's no insistence on which of those 8 symptoms are the core symptoms. And a problem that is related to that is that many conditions that are not CFS can present with some degree of fatigue. So if you don't have core symptoms and you don't apply severity criteria to those symptoms, you can get classification errors that are often very damaging to families. For example, a number of years ago there was a study with a fairly broad and weak definition of CFS that somehow accrued a population with a very high proportion of post-traumatic stress disorder and led to, I think, the erroneous conclusion that early childhood abuse is somehow a risk factor for CFS. That is not something that those of us who are pediatric CFS clinicians see, and so it highlights the importance of getting the definition correct. The other problem with the Fukuda criteria is they're now over 20 years old, so they don't reflect the recent research observations, especially the ones that emphasize the impact of orthostatic intolerance, which is something we've been working on, and post-exertional malaise. By orthostatic intolerance, I mean a group of conditions, circulatory conditions, in which symptoms are worse with upright posture and tend to be somewhat better with lying back down. Here, for example, and I'll highlight data from this study that we did, are the symptoms from the Fukuda definition in 55 consecutive adolescents and young adults with CFS. To give you a sense of the frequency of these. Unrefreshing sleep, some or most of the time, was present in just about everybody. Post-exertional malaise, at least once a week, was there in 95%. Keep in mind that patients can reduce the amount of activity they do so that they stay within their limits and don't aggravate post-exertional malaise. So this is something that has to be taken into account as well. Cognitive problems occurring several times a week were present in 82%, headaches in 76%, and then you see a symptom that wasn't even in the Fukuda criteria, and that is lightheadedness. This occurred several times a week in our cohort, and that would be a feature of orthostatic intolerance. Notice that some of the other pain symptoms like sore throat, arthralgias, and tender glands are less frequent and not really definitive for this illness. Post-exertional malaise, as many people have pointed out, is more than just an increase in fatigue. Patients can usually power through a little bit more activity than they've been used to, but not only do they generate increased fatigue, but they get trouble thinking and concentrating, more pain, flu-like symptoms, increased lightheadedness, and others. A number of groups have shown that this post-exertional malaise can extend well beyond 24 hours, and so that's something that has come to light in the last decade. Post-exertional malaise is probably not unique to CFS, but it's much more common in CFS than in depression. And as clinicians, we usually recommend to our depressed patients that they exercise, and in response to exercise, people with depression usually feel better. They just feel better, and that's a component of all programs for treating depression, whereas those with CFS can risk aggravating their PEM. One study that I like a great deal that came out a few years ago came from the group with Alan and Kathleen Light at the University of Utah. And they added some real science to this phenomenon of post-exertional malaise, because often people would see somebody struggling but able to do an inning or two of the family softball game on the 4th of July, but then be in bed for 2 days, and it didn't make sense to people. What in the world could be going on? Well, the Lights looked at a measure of what might be going on in the body by looking at a number of genes on the right-hand part of the screen that were sensory genes, adrenergic genes, and immune receptor genes. They had patients who were healthy on the top do a 25-minute exercise to about 70% of their predicted maximal heart rate. And in the bottom are the CFS patients. And really all you need to have is one glance at this slide to know that these are two entirely different populations. They measured blood work at baseline, 30 minutes, 8 hours after exercise, 24 hours, and 48 hours after exercise. Notice that at the top that the healthy individuals had very minimal changes in the messenger RNA expression of these metabolite receptors on their white blood cells, whereas people with CFS at the bottom had a marked increase in these in gene expression beginning at 30 minutes, peaking at 24 hours, and still present at 48 hours. And this actually correlated beautifully with the severity of the symptoms they reported. So there's something very profound going on at a biological level in people who have post-exertional malaise with CFS. And I think these studies have helped ensure that this remains an important element in the disease definition. In 2015, a report came out from a committee that I was a member of from the Institute of Medicine, suggesting that we needed to really use the information of the last 20 years and come up with a better way of describing and defining the illness. And the criteria recommended by the Institute of Medicine committee were more focused on the core symptoms of the illness than many other definitions had been. And these included impaired function, this inability to do as much as you had done in the past, post-exertional malaise as a core feature, unrefreshing sleep, and either cognitive impairment or orthostatic intolerance. And this was the first time this was a bigger emphasis on orthostatic intolerance than had been there before. These symptoms ought to be present at least half of the time and with at least moderate intensity. So the Institute of Medicine criteria included a focus on symptom severity. For clinicians faced with the patient who might have features of ME/CFS and presents with chronic fatigue, the differential diagnosis includes most commonly things like insomnia and poor sleeping. You can see symptoms that overlap a lot with ME/CFS with those who are overtrained in athletics, perhaps running too many miles in a week as part of their track routine. They start getting lightheaded, a bit irritable, fatigued, and unable to perform at their level of competition. We can see fatigue with allergies. Anyone who has allergic rhinitis in the spring knows that fatigue often accompanies that. Any infectious or inflammatory condition can cause fatigue. Iron deficiency, even in the absence of anemia, can do so. Depression and anxiety are common causes of fatigue in the general population. There's obstructive sleep apnea. We'll talk a little bit later about orthostatic intolerance. We look for medications that could be causing fatigue. There are a number of endocrine disorders, including most commonly hypothyroidism. All clinicians know that. There's been some increased emphasis on hereditary disorders of connective tissue such as Ehlers-Danlos syndrome. Those patients often overlap with those who have ME/CFS, and probably there are a proportion in each group who really have the other condition. So that's something that needs to be looked at more carefully. Basically, any other systemic illness can give you chronic fatigue, so the process of evaluating patients needs to look carefully at all organ systems in the body. This slide shows some clinical discriminators of fatigue that we've found helpful. For those who have a neuromuscular disorder such as myasthenia gravis, the clinical pearl is that they really have weakness that gets worse the more they exert those muscles. Whereas weakness isn't typically a cardinal feature of ME/CFS in adolescents unless they've been sick for years. Those who have obstructive sleep apnea interfering with ventilation often have much more daytime somnolence than our chronic fatigue patients, who typically are bone weary but often have a hard time falling asleep. Those who have heart and lung disease as a cause of their fatigue usually are short of breath during effort. That is, as they exercise, they are getting tired and they are intolerant of the effort, whereas those with ME/CFS usually can complete at least part of an exercise challenge, but they feel much more symptomatic afterwards. Adrenal insufficiency is a hormonal condition that will mimic a lot of the symptoms of ME/CFS. Those patients should have a fairly prompt drop in blood pressure on 2 to 3 minute orthostatic testing, and they usually have a low sodium, so that gets picked up fairly readily. Bronzing, as occurs in Addison's disease, and hyperkalemia, elevations in potassium, are later findings, less common as presenting features. And lastly, Chiari malformation is something that can be associated with fatigue. About 70% of those with Chiari malformation will have chronic fatigue, but they almost always will have occipital headaches, brisk deep tendon reflexes, and other neurologic exam findings. This slide shows a number of red flags that clinicians need to think of for serious conditions other than ME/CFS. First one is weight loss. That would often indicate malabsorption or some kind of inflammatory disorder in the bowel. Fevers are fairly uncommon with established ME/CFS. Patients have a lot of temperature dysregulation. They feel chilled and feel warm, but they don't actually have full temperature elevations. Paralysis in sleep and cataplexy would indicate narcolepsy as the diagnosis rather than ME/CFS. Clubbing of the fingers would suggest a cardiorespiratory problem or perhaps some chronic inflammatory condition. Patients who have erythematous swollen joints obviously would need to see a rheumatologist. And then it's important to look carefully for abnormalities on the neurologic exam. Let me just show you somebody who was quite a challenge to us. This is a young girl who presented with postural tachycardia, severe fatigue, really was unable to attend school, and I went over her neurologic examination time after time. By about the 6th year of her illness, she had some pathological reflex changes that led us to get this MRI. And what this showed was that in the cervical spine, along here you see very little of this white spine, cerebrospinal fluid on either side of her spinal cord here. So she had a congenital narrowing of the cervical spine, and here she had a disc bulge that was actually pressing further on that spinal cord. When this was actually fixed and replaced by a spine surgeon, she had a marked improvement not only in her fatigue but also in her POTS, which resolved, and interestingly enough in her anxiety. And we presented at the international meetings in October 3 patients with a similar appearance of their cervical spine. So suggesting that one has to really be careful to look for evidence of narrowing of the cervical spine and crowding at the base of the skull. It's a very uncommon trigger to ME/CFS symptoms, but it reminds us to pay attention to the neurologic examination. Let's move on now to talk about how adolescents with this illness present. And I want to show you a 17-year-old from the Baltimore area who came in to see us a few years ago. She had developed fairly gradually the onset of fatigue, headaches, and joint pain when she was 15. Around that time she was starting to get some dysmenorrhea or menstrual cramping, and her physician appropriately began her on a birth control pill, which helped a bit with the cramps. Around 2 years later she was at the beach in the middle Atlantic part of the US and developed Lyme disease, which also was associated with widespread joint pain. She was treated with appropriate antibiotics for a month, and then the rash of the Lyme disease and her widespread pain both resolved. But 2 months later, she started getting worse fatigue, increased lightheadedness, joint pain, headache, sore throat, poor concentration. Her fatigue was there despite a pretty good amount of sleep for an adolescent, 7 to 9 hours each night. Sleep was unrefreshing, and for the first time in her life, she was taking a nap after school on most days. The interesting part of the fatigue was that it was worse whenever she would get her menstrual period, worse when she would stand in line or go shopping. And we often tell our trainees that if you've got an adolescent who can't go to the mall because of physical symptoms, then you've got a real problem on your hands. She was also worse if she exerted herself. So it's starting to come together as the pattern of ME/CFS. This young woman could attend school full-time, but she just couldn't take part in a lot of the extracurricular activities she had enjoyed before. Headaches were bilateral, and the one clue there was that she said they were more common if she was sitting for a long time, suggestive of an orthostatic component. She reported some low back pain when she would stand, and she had pain in the right hip and knee that were different than what she'd had before. She noticed that her right hip would sublux and come in and out of the socket, not a full dislocation, but just a bit unstable. She was zoning out a lot more in class. She was lightheaded whenever she would stand up, and this was more common in the morning when her blood volume was lower, and she fidgeted a lot when she was standing. In addition to all that, she had some seasonal nasal congestion, especially in the fall, and overall she reported a wellness score of 70 out of 100. And that wellness scale is something we use a lot because it's quick, it correlates nicely with longer quality of life measures like the SF-36, and it's anchored at 0. We ask them, how have you been feeling the last month overall? 0 means I'm dying, 100 means I'm as good as I could imagine feeling. So it's about a percentage of optimal health, and she was ranking herself at a 70. Now in our cohort study, a 70 would be in the upper part of the range of wellness scores we saw in our CFS population. The mean was a score of 50, and in the controls that we enrolled at the same time, the typical score was 85 or higher. The clinical evaluation needs to include obviously a careful history, and we often supplement that with questionnaires that might look at cognitive function, activity level, and mood states, just to be sure that the child who's in the clinic smiling at you doesn't have all kinds of other problems that are more related to depression. The physical exam, as I mentioned, needs to include a careful neurologic exam, a Beighton score, which is a measure of joint hypermobility. I'll show you how to do that in a minute, as well as range of motion measures that we've come to focus on in these adolescents. In our clinic, we do an orthostatic test, a 10-minute standing test in everybody who presents with prolonged fatigue or chronic fatigue because of the importance of orthostatic intolerance in creating fatigue in the subset. The screening lab studies that you do to evaluate people with ME/CFS include the same kinds of things that clinicians look at for patients who have failure to thrive. So that includes a CBC, some measure of inflammation like an ESR, serum chemistries, thyroid function, urinalysis. Most of us now do iron studies because of the influence of iron deficiency on fatigue, vitamin B12, which is more deficiency of which is more common if you're a vegan or if you are on proton pump inhibitors for acid reflux, and we do celiac screening. And then depending on the whether Lyme is endemic in that area, we might check for Lyme and tick-borne infections because of the overlap with those conditions. Other lab studies are not indicated unless there's some other clue. So in the patient who has low platelets and a malar rash, obviously you're going to get an ANA to look for lupus, but there isn't a big group of lab tests that one has to obtain. So if we go back to the 17-year-old I was describing, her examination showed, as you might have expected, some nasal bogginess that would go along with her allergic rhinitis. She was hypermobile. She had a Beighton score of 5. And she had right hip tenderness with simple internal and external rotation maneuvers of the hip. She was tender on palpation of the muscles in the lumbar area. She had a very limited straight leg raising. For a hypermobile child, you'd expect them to develop stretch at somewhere between 50 and 60 degrees of straight leg raise. But for her, it occurred at 36 degrees, which seemed out of sync with her general hypermobility. We then went to the standing test, and she was lightheaded throughout the 10 minutes of standing, did not quite reach the criteria for POTS, which would be a 40 beat per minute increase in her heart rate during standing, but this was suggestive. Her lab studies were normal. Her sedimentation rate was 12. So how do you bring these problems together? Well, I thought she had mild chronic fatigue syndrome, a clinical diagnosis based on her symptoms of recurrent lightheadedness and her response on the standing test of low orthostatic tolerance, joint hypermobility. She had postural dysfunctions and hip pain. She had the menstrual cramping still, even with the birth control pills, and she had an increase in her fatigue every time she had a period. Plus, she had the allergic rhinitis. And one of the points I want to make about this list is these are common conditions in general practice, in pediatric and young adult practice. There's nothing that mysterious, and so it's fairly easy to start tackling these using fairly conventional methods. What we do for the treatment of CFS is we begin with an explanation of what we understand about the disease. We demystify as much as possible and emphasize to people that just because they're lightheaded when they stand, they shouldn't take to bed, that they need to try working through that. And we describe the generally favorable prognosis, acknowledging that there are certainly a number of patients in anyone's adolescent CFS clinic that we have not got the science or the understandings to really improve much yet. We then develop working hypotheses about the primary influences on fatigue, which might be different for each person. We begin non-pharmacologic therapy, so if the person has a lot of sleep dysfunction, we might give them some advice about making sure they're turning off their electronic devices and not looking at the phone and the emails and the Facebook right before bed. If they have orthostatic intolerance, we're going to increase their salt and fluids as the foundation of that treatment, teach them some postural countermaneuvers that I'll show you in a minute. Some way of coping with the loss of function. Some people have access to cognitive behavioral therapy, which, if it's done in a flexible manner and not proposed as a curative thing, can be helpful in a subset. We then usually use more manual forms of physical therapy to help bridge people's inability to do exercise, and then once they're able to tolerate exercise, we want them to do a flexible, graded increase in the exercise, but not a rigid advancement of their exercise regimen. We fairly early on begin pharmacologic therapy, again focusing on what we think are the dominant influences on the symptoms. So if somebody's really lightheaded all the time, that might be the focus of the first medication. If their sleep is horribly disrupted, that might be the focus. Similarly for pain, headaches, allergies, menstrual dysfunction, and certainly low mood and anxiety need to be treated if they're present. And then the last point on this slide is that we have to reassess these patients at regular intervals and then repeat those 4 steps, because if you've helped the sleep dysfunction, something else will then emerge as the more dominant symptom that needs the attention at that moment. Back to this 17-year-old. So we knew that she had allergic rhinitis. It was pretty easy to start her on a non-sedating antihistamine. She still had menstrual flare-ups in her fatigue, so one of the tricks we can use to help with that is to move them from having a monthly period to a period every 3 months, using a continuous active pill regimen for the first 84 days and then a week off. And that would reduce 2/3 of the menstrually related increases in fatigue. We knew that she had restricted movements on her examination, so we sent her to a physical therapist. And to address her orthostatic intolerance, we increased her salt and fluid intake. We suggested compression garments and taught her some of these postural countermaneuvers. Some of them are shown on this slide. Many of the patients with orthostatic intolerance will come in and be seated like this girl with their knees to the chest, which often helps get more blood flow back up to the heart and brain. They often sit also with one leg tucked under. They stand with their legs crossed like this and have a number of postures that they don't really know why they're doing, but they know they feel better doing them. Look for those on your clinical evaluation. So we sent her to the physical therapist, and he identified some reduced mobility of the lumbar spine. And the big thing he found was that she had a rotational abnormality in the pelvis, with the left hemipelvis rotated anteriorly and the right posteriorly, resulting in a number of compensatory changes in the lumbar and thoracic spine. He even thought that the left hemidiaphragm was not functioning well and probably contributing to her fatigue. So he began weekly treatments, sometimes twice weekly, and we had her come back, and at the 2-month follow-up she was still having a lot of orthostatic lightheadedness and problems with concentration. So we then chose as her first prescription medication, other than the changes we'd made earlier, methylphenidate in the extended release form. And methylphenidate is interesting because it's a very good medication for treating either postural tachycardia or neurally mediated hypotension. It works very nicely as a vasoconstrictor, and it can also help with concentration. There are a couple of small randomized trials using methylphenidate and related stimulants for people with CFS, although this doesn't often get much attention. So she did better with that, and at the 4-month point her wellness score was up from 70 to 82, and she continued improving gradually, I think, from the medications, but also from the physical therapy. I'm going to fast forward to the 1-year follow-up. This was one of our most successful treatment results. This young woman had finished her first semester at nursing school. She was walking 3 or 4 miles a day on campus, back and forth to class, working out vigorously in the gym for about 45 minutes at a time, 3 times a week. And at this point, her wellness score was 98 out of 100. I'm not sure most of us are at that point. I'm certainly not. One interesting comment to make here is that many people will argue, I think incorrectly, that if you could just get all these people with CFS to start moving and walking and advancing their exercise, that's all you need. There's nothing more complicated than that. But this woman sort of disproves that theory, because there was a natural experiment. We had trouble getting her methylphenidate for a week, and even though as fit as she was at this point, she immediately had an increase in her lightheadedness, headache, and fatigue. So it wasn't deconditioning at all. It wasn't the severity of deconditioning that affected things. It was that we were able to control many of her symptoms with the regimen we had her on, and so we were managing her problems, not curing them. She's continued to do well for the last 5 years, working as a nurse now. This is a diagram I often use in talking to our patients. The items in green are the conditions that this young woman had, but the point of a slide like this is to show that orthostatic intolerance is a big influence on chronic fatigue syndrome symptoms in our view, but that it's not one size fits all. You can have a combination of other factors that affect both the orthostatic intolerance and the CFS symptoms, including depression, which is not uncommon as a secondary phenomenon if your function has been so severely impaired by the CFS that you can't continue with schooling or other activities. Anxiety is interesting because it has some of the shared physiology of orthostatic intolerance. Anything that increases catecholamines can aggravate both problems. We see food allergies in a number of patients. We published a paper last year in which we had looked at the 55 patients in our cohort study, 31% of whom had evidence of milk protein intolerance, and we think that that needs to be treated before you're going to get success with any of the other treatment regimens. The milk protein intolerance was heralded by epigastric pain, reflux, and early satiety, often with mouth ulcers. And some of these patients had had a lot of colic and reflux as infants and needed soy formulas or other amino acid formulas, began to tolerate milk for a period of time. Then the immune tolerance of milk seemed to change around the time they got the CFS, often immediately after mononucleosis. So that's an important one to think about. Inhalant allergies and asthma are common. Often the illness is triggered by an infection. The movement restrictions we'll talk about in a little bit later. Migraines are common. A small subset will have neuroanatomic problems. Ehlers-Danlos syndrome and joint hypermobility are overrepresented in those with CFS, and we'll talk about that a bit further. And occasional patients can have even pelvic vein incompetence or pelvic congestion syndrome, which is another treatable contributor to these problems. So this is not an exhaustive list. It's meant to simply illustrate the potential for treating each of these individual components as a way to get people to an improved level of function. Let me step back a bit and talk about some of the things we've learned in the last 15 to 20 years about CFS. We know that it affects previously active individuals in all socioeconomic strata, but that there's a higher female to male ratio of 3 to 4 to 1. It's described, but much less common before the age of 10, and it peaks at age 40 to 49, so it doesn't keep getting more common as you get older. The prevalence is estimated, prevalence is estimated at 1 to 5 per 1,000 children. It may be more than that. We don't have great epidemiologic studies. And as you saw in the slide before, it has heterogeneous precipitating and perpetuating factors. There's a genetic component in that it's more common in identical than fraternal twins. And the proven treatments for the entire illness are limited. We know that there are studies suggesting that CBT and graded exercise may help some people, but I think it's important to emphasize that these are not curative. The effect sizes have been judged by the Cochrane collaboration to be quite modest, and no studies have been performed in the severely affected patients. In addition, as many people are aware, there have been some recent challenges about the methodology of studies like the PACE trial that really question whether this was, these are things being promoted by people who believe more in the theology of CBT than in the actual science. The prognosis of pediatric ME/CFS is thought to be better than that starting in adulthood, but we don't have a lot of comparative studies, and clearly some people who get the illness in adolescence have quite prolonged illnesses, and that poses a challenge to our scientific understanding. Just a word about the impact of the illness on health-related quality of life. Here I wanted to show you the PEDS-QL, which is a questionnaire that looks at quality of life commonly used across a lot of conditions in pediatrics. And I've taken our pediatric CFS patients and our healthy controls from the cohort study and plotted them along with some data from the University of Cincinnati. And again, these are the same questionnaires being administered to everybody. Notice that the people with CFS had worse function, and part of that function is determined by school attendance and activities. Worse function than people with cystic fibrosis, eosinophilic gastroenteritis, diabetes, and sickle cell disease in pediatrics. So I think this is surprising to most of my pediatric colleagues, but the impairment in function really is quite profound, and CFS is often the most common cause of prolonged school absence. Here are the subdomains of the PEDS-QL questionnaire. Notice that the school is way different than that for the scores for the healthy controls, and scholastic function correlates best with overall physical function, as has been shown by other groups. Of the things that the patient I presented earlier had, let's dig in a little bit to learn what we know better now about infection and its contribution to the illness. Ben Katz's group in Chicago followed 301 adolescents who had acute infectious mono and looked at them over the next 2 years to see what proportion developed or met criteria for CFS and ME. And at 6 months, notice two things. One is that about 13% of the patients met criteria, and it was vastly different between boys and girls. By 12 months, 7% still were ill, and by 24 months, strikingly, 4% remained sick and met the criteria. after a number of acute infectious illnesses, about 10% will get CFS, the main risk factor being the severity of the initial infection rather than the behavioral state of the person before they got sick. Thus far, and this is a bit more controversial, active infection has not been detected in the chronic state, although people are vigorously pursuing the question of enteroviral infection and other viruses, and some clinicians will try antiviral therapy, but the evidence in pediatrics is not great. So we wonder whether infection acts as a hit-and-run phenomenon, triggering some other physiologic dysfunction, but not directly causing symptoms. And I'm just going to go back for a second. We haven't had as many studies in pediatrics that look at cytokines and natural killer cell function as there have been in adults, so the literature is a little bit limited. But I want to draw attention to one really important trial that was conducted by Peter Rowe in Melbourne, Australia. Kathy did a randomized trial of intravenous immunoglobulin for adolescents with CFS, and she gave 1 gram per kilogram on 3 occasions a month apart, and then followed people. And she looked at the percent that had at least a 25% improvement over their baseline in their functional scores. And this was significantly different by 6 months of follow-up. So the IVIG group did much better, and amazingly, this is the only study that's ever been done in pediatrics using IVIG for adolescent CFS. The results in adults are mixed, but this could be another thing that we could bring to the table for our patients. And here we are 20 years later with no confirmatory studies, which is a shame. We'll talk a little bit now about orthostatic intolerance. The 2 main forms of this, as many people know, are postural tachycardia syndrome and neurally mediated hypotension. This is synonymous with vasovagal syncope, but because many people have not had syncope in day-to-day life, we prefer the term NMH. POTS requires a 40-beat increase in heart rate in adolescents. It's a 30-beat increase in adults, but you have to use a 40-beat difference in adolescents, and that has to occur in the first 10 minutes of standing or head-up tilt testing with orthostatic symptoms and without any drop in blood pressure, without orthostatic hypotension in the first 3 minutes of standing upright. You can also meet the heart rate criteria for POTS if you exceed a heart rate of 120 beats per minute. Neurally mediated hypotension, on the other hand, doesn't usually have POTS preceding it. This is a tracing from a medical student at our institution who was getting near faint every day during her first year of medical school. When we put her on the tilt test, her heart rate went up 9 beats, and then suddenly at the 5-minute point, which was pretty early for most people with this disorder, she dropped her blood pressure down to 50 systolic, which was not compatible with remaining upright. One thing that we and everybody else who sees this have observed is that acrocyanosis is common in orthostatic intolerance and in ME/CFS patients. So here's this purple discoloration in an adolescent who'd had to stop college because she couldn't continue due to fatigue and other symptoms. This is a couple of minutes in. That's my hand as the color contrast. And on the right-hand panel, I've impressed my fingers on her skin to see what her capillary refill is, stepped back, picked up a camera, fiddled with it, focused it. I'm not too good with machines. And so something like 7 or 8 seconds went by. She still had no capillary refill. This is a pretty profound circulatory problem. We first noticed an overlap between the symptoms of CFS and the symptoms seen in people with neurally mediated hypertension, and began doing tilt testing studies back in the mid-1990s and published in The Lancet and JAMA. And one of the points from the JAMA study is that when we looked at the response of these patients to open treatment of their orthostatic intolerance, they went from a wellness score of about 35 up to 70 after 4 months of treatment. So it didn't cure too many people. There might have been 1 or 2 who were really well managed, but it led to a big improvement in their overall function. And this is essentially what we see to this day. So this has been recognized now by most CFS clinicians as one of the most treatable forms of comorbidity in the illness. When we look at the orthostatic intolerance rates in pediatric ME/CFS, every study that's been done has shown a higher rate of orthostatic intolerance in this illness. There are no studies that have shown otherwise. Julian Stewart in New York found that 96% of his group with CFS had orthostatic intolerance. You can have problems with cerebral oxygenation. And Vegard Willer in Norway did a very nice study. He did a 20-degree head-up tilt test, and even with such a modest orthostatic stress, the CFS patients had higher heart rates and higher sympathetic tone. There is an overlap between ME/CFS symptoms and those with POTS, as people have seen in adults as well, and in Dr. Stewart's work, lightheadedness is seen in 100% of the POTS patients. Many of them also have fatigue, and they have lower prevalences of the other main symptoms of CFS. And we often think of POTS as basically CFS light. One study I want to draw attention to from that group, and this is showing Dr. Marvin Meadow and Dr. Stewart here, it came out in 2012, and it suggested that increasing the degree of orthostatic stress impairs neurocognitive function in people with CFS and POTS. And I don't want to spend a lot of time on the details, but essentially they had patients and controls, patients in black, controls in gray, lying flat on the tilt table doing cognitive tests. And notice that at baseline there was no difference between the CFS patients and the controls. As the angle of the tilt went from 15 to 30 to 45 degrees, you started seeing worse reaction times and more errors in those with CFS, suggesting that their cognitive function and their orthostatic tolerance were not separated. You don't, that one may be contributing to the other. And the same kind of thing was seen if you increased the complexity of the test that they were being asked to do. So this was an important study showing that these two things are associated. The patient I presented earlier had joint hypermobility. Let's spend a bit of time talking about that. I mentioned the Beighton score earlier. This is a 9-point, very simple, couple of minute clinical maneuver in which the patient is tested and gets 1 point on the left and right if they can bring the fifth finger back past 90 degrees, as you can see in this bottom panel. You get 1 point on each side for being able to touch the thumb to the flexor aspect of the forearm. You can get a point on each side for more than 10 degrees of hyperextension at the elbow, and for this you really need a goniometer to make sure you're not just eyeballing incorrectly. This panel shows hyperextension of the knee more than 190 degrees. You get a point on each side for that. And the 9th point is for being able to put your palms flat on the floor, bending over at the waist. A score of 4 is consistent with hypermobility, and the maximum would be 9. And in our studies, in our clinical work, we also ask the patients, what other tricks can you do with your joints? And they can often do some rather extreme things, including put their foot behind their head. Look for striae, which can occur. These stretch marks can occur early in people with this kind of cutaneous laxity. They can have pisogenic papules, which is protrusion of soft tissue through loose fascial layers at the ankles. And they can be at risk for delayed wound healing. Here's a very widened scar in a young woman who'd had a laparoscopy procedure. The laparoscopy site dehisced, came apart on 2 occasions, needed to be restitched. And the surgeon and the plastic surgeon were starting to think that this girl might have Munchausen syndrome. But really what she had was Ehlers-Danlos syndrome, which is known to be associated with that kind of poor wound healing. And so there was no attempt to create problems. When we looked at comparing healthy individuals in yellow with our CFS patients on their Beighton scores, look at the vast difference here in the distribution of hypermobility. In the yellow, in the healthy people, 24% had a score of 4 or higher. And that's about what you see in the literature on joint hypermobility in high school students. Those are the dancers, the gymnasts, the swimmers for whom hypermobility is a great advantage in their activity. They don't have an illness. Whereas our CFS patients, 60% had a score of 4 or higher. So this is a genetic trait that's present from earlier in life and somehow contributes to their problems. We think possibly by encouraging more pooling of blood in the lower half of the body when they stand and aggravating their orthostatic tolerance. I want to spend a bit of time on movement restrictions. We've noticed an increased prevalence of postural abnormalities and movement restrictions in our patients. Notice this young man with a very head-forward posture, a lot of thoracic kyphosis, and our physical therapy colleagues led by Rick Violand have noticed that they could reproduce CFS symptoms by selectively putting some mechanical tension on the neural tissues, by increasing adverse neural tension. And in one of our pilot studies, we had a young man come in and we were going to increase the straight leg raise. We lifted his leg up to 10 degrees, left it there for 2 minutes, checked heart rate and blood pressure, went to 20 degrees for 2 minutes, and so on up to 60 degrees. And we were thinking that we were probably aggravating heart rate and blood pressure with stretching the nerves. But what we saw was that he came in with a score on his fatigue score of 5, and it went up progressively through this maneuver, and he actually was unable to go home afterwards until he'd been drinking Gatorade and eating crackers for an hour. He felt too unwell. We made his cognitive fogginess worse in green, even though he was lying down and we were raising his leg up, which ought to improve blood return to the heart. He got more lightheaded with this maneuver, and he even had some visual blurring. And we've explored this further, one in the cohort study I mentioned where we had 48 pairs matched by sex and Beighton score category, and we put them through a range of 11 range of motion procedures. And I won't go into detail. This was published a couple of years ago in the Journal of Pediatrics. But again, look at the difference in the distribution for CFS patients and controls. This was a highly significant difference, showing that the CFS patients were more restricted, and that's seems paradoxical because I just finished telling you that they're more hypermobile, but the hypermobile patients can get focal areas of restricted movement that can be part of their symptom aggravation. The Solve ME CFS initiative funded this study where we took people with CFS and exposed them to a true straight leg raise strain and a sham strain. The sham is in the dashed bars. And we asked them to tell us whether their symptoms, 5 main symptoms, had increased on a 0 to 10 scale. We looked at how many had during the 15-minute straight leg raise maneuver. And we looked at the proportion who had a more than two or more point increase in their symptoms. And here we're showing that 80% had a 2 or more point increase in at least one symptom, compared to the people who didn't get the true straight leg raise. And then if we were getting a 2-point increase in 2 symptoms, there was a difference, and it was even more dramatic if you looked for 3 symptoms increasing by at least 2 points. So something about adding this neuromuscular strain increases symptom intensity in this illness. We don't know the etiology of that. It could be some problem with nerve swelling or nerve movement aggravating other factors. It could be related to neuroinflammation or other factors. We didn't look at the mechanisms. We just wanted to describe this so others could start looking into it as well. I mentioned earlier the 17-year-old who did incredibly well, but I don't want people to end with the sense that everybody does well. Here's the severe end of the spectrum, and we struggle the most with patients like this. This is a 22-year-old with ME/CFS who started getting some symptoms at age 9 with a decrease in stamina, became much worse following a sinus infection at age 13 and started to meet the criteria for the illness. By grade 8, she was unable to attend school due to her symptoms. It wasn't that she didn't want to go to school, it was a couldn't get there rather than a don't want to get there. And now she's mostly housebound. She can help out with some babysitting activities, but too much activity outside of the house really causes a crash that lasts several days. And we've identified a number of comorbid conditions. POTS, like we usually see. She has a low immunoglobulin G, but even treating her with IVIG has not led to improvement. She has a low carnitine level for unknown reasons. We've done all the metabolic testing looking for inborn errors of metabolism and mitochondrial dysfunction. If she has that, it's awfully subtle. She has migraines, she has recurrent hives, that raised the question of mast cell activation syndrome. She's had gallstones, even though she's a very thin girl. She has a lot of irritable bowel syndrome and abnormalities on the electrogastrogram, and she has some movement restrictions affecting the brachial plexus. So these are the patients that really keep me up at night wondering what else can we do, what else is going on to cause their symptoms. Overall, this is the kind of improvement in wellness scores we saw in our 2-year cohort study. Again, emphasizing we didn't get everybody better, but there's a lot of potential for improvement with individualized therapy. So I want to conclude by mentioning that this is a disease associated with substantial morbidity. The physical examination is often abnormal. Look for acrocyanosis. Measure for tachycardia or hypotension in the first 10 minutes of standing. Look for joint hypermobility. Movement restrictions are very common. And there are a lot of treatable comorbidities, many of which are amenable to established therapies. We still know that the cause of symptoms and the optimal therapy is not well established for everyone and certainly requires more study, and especially this is true for the severely affected patients. Just a brief word on some resources that might be helpful to clinicians. One is the adult primer available at the iacfsme.org, and a pediatric primer has been submitted for publication, so watch for word on that. I did a chapter for one of the adolescent medicine textbooks that might be helpful to people, and I think a very helpful resource that reviewed the evidence is from the IOM report. Online, this organization has been incredibly helpful, and a lot of the webinars might be useful. The IACFSME has meetings that can help. I did a webinar about 6 years ago now, Zahir, that is still on YouTube for those of you who need some guidance in how to manage orthostatic intolerance. And for more on that, you can look at Dysautonomia International, which is another nonprofit patient advocacy group, and the Ehlers-Danlos Society has a good website, and both Dysautonomia International and the EDS Society have great patient-oriented summer conferences, very good for physicians as well. So I'll end there, thanking the people who made my clinical efforts and academic efforts possible in the last 20 years. So thank you.
Dr. Rowe, thank you so much for this amazing overview. This will not only be helpful to our patients and the community, but also to healthcare professionals, because they can go back to this and look at special cases and guide their practice. So I appreciate you doing this. I appreciate that very much.
Sure.
I would love for you to spend a minute before we get to the questions on that new adolescent and children primer. I have been working with the incredible Ken Friedman and the incredible Rosemary Underhill to facilitate the publication of that primer, and you are a key driver behind that. So can you tell us a little bit what's the objective of this and how, what's the status?
Yeah, so this is a very comprehensive review of the epidemiology, symptoms, diagnosis, and management of pediatric ME/CFS. Ken Friedman, Rosemary Underhill, and Alan Gerwit were the people who proposed the idea, and a number of CFS clinicians from around the world met about every week to 2 weeks over the last 2 years to put this together. With Kathy Rowe from Australia, Julian Stewart and Marvin Meadow from New York, Nigel Spate from England, Malcolm Schwartz from the U.S., Roz Vallings from New Zealand. We really had, and I hope I haven't left anyone out, but it was a very useful effort, and we brought together a lot of opinions and a general consensus about how to treat the adolescents with this disorder. So we're hoping it's going to be very helpful for advancing the quality of care for the people that none of us can, that we can't all see individually.
That's wonderful. It sure will, and we are looking forward to this being published so that we can promote it even further on our channels. Dr. Rowe, you touched on, we are 1 minute past the hour, but you touched on many issues that we received questions on. In fact, let me just maybe run 2 or 3 by you very quickly, and I appreciate you working with us after this to answer all of them. I appreciate that very much.
Sure.
And we will list them on our website so that folks can come back to them anytime. Now, one question here. A while ago, Dr. Rowe reported finding a simple leg lift could cause an increase in ME/CFS symptoms in some patients. And I believe you touched on that towards the end. Is there any new information about this, i.e. what might cause it and or how to prevent it from occurring?
No, we haven't done anything on the causation of it, but what we find clinically is that if you can get people to a good physical therapist who can work on very gently mobilizing these tissues, they use a variety of techniques that are manual techniques. In other words, they don't require the patient doing the effort and exercising, which might at that early point trigger symptoms. If they can get people moving more freely, then they often start to tolerate exercise better. There's sort of graded increases in exercise that can be very helpful for things like orthostatic intolerance. If people do too much exercise too soon, they'll get flared up, and that's why we think of the manual physical therapy as a bridge to the toleration of exercise. But I think a really interesting question is, what's going on in the illness to make people have such tightness in the nervous system? This is a neurologic finding, and so that deserves more therapy, but it's very hard to do biopsies of nerves, for example, because you create chronic pain by doing that.
Great, thank you so much. Here another question that also you illustrated with a case of a 17-year-old. This is about how you decide if a patient has ME/CFS or chronic Lyme disease. I think that case presented with a chronic Lyme disease, and you described how. Okay, can you just summarize that for us?
Yeah. So it's clear that after a variety of infections, including Lyme, we think you can get more chronic symptoms. And a big debate in the medical community is, to what extent is that because of persisting Lyme disease versus some other phenomenon. And this young woman was one of the ones who did not, we don't think, have persistence of the Borrelia organism because we didn't give her more antibiotics. She got better with other maneuvers. But I think it's a complicated issue about which we need more study. One of my colleagues in Baltimore, Dr. John Alcott, has been doing a study where he sees people with adults with a Lyme disease rash, treats them, and then repeats their blood work. And after 6 months, I think some of the preliminary data were that only 70% of people have antibody evidence of having been exposed to Lyme. So there's a proportion of people who don't get a serologic response where you could identify something as Lyme, and that's kind of scary. So I think there's a lot of gray out there in that question. I think it's a good question. I don't think we have the answers yet.
Yes, thank you so much. And I am curious about something you said. You said, and you showed data, that the intensity of the infection, the severity of the infection, correlates with the likelihood of getting ME/CFS, if I get you properly. What do you mean by the intensity of the infection?
Yeah, it's been shown in the Dubbo study in Australia among adults and in the Ben Katz study in Chicago among pediatric patients that the people who were sicker, who were less able to move around during the acute phase of the illness, were the ones that were more likely to get to meet criteria for ME/CFS at the end of 6 months. So some of the studies had speculated, oh, it's just the person's willpower, yes, or it's something about their individual psychological makeup. But I think those studies put the lie to that notion and showed really it's a consequence of the intensity of the illness.
Great.
We don't know
as measured by titer, or as measured maybe by viral load or titer, or things that are tangible rather than. Right.
And I think we need to figure out what factors go into that.
Great.
At a biological level.
Yes, absolutely. And last question here, regarding mitochondrial dysfunction, what's your opinion on that in the context of your work? can you, and without mentioning names, there's the questioner here asked about the work of Dr. Sarah Mayhow that we respect. What do you have? Do you have a few sentences on placing bioenergetics and mitochondrial dysfunction in the context of pediatric ME/CFS from what you have seen?
Sure. Yeah. So one of the things that's intriguing, and I think makes a certain amount of sense to everybody in medicine, is that if your end symptom is fatigue and inability to tolerate exertion without an increase in symptoms, it would make sense that there might be some dysfunction in the mitochondria. The challenge has been that patients with known mitochondrial dysfunction usually have some manifestation of that that's measurable on muscle biopsy or in tests like organic acids and plasma amino acids. And we have not found that to date with any great certainty in the pediatric and adolescent ME/CFS patients. It may be that our measures are not sophisticated or subtle enough to pick up what's there. My patient who had the low carnitine levels, for example, we thought for sure would come up with an abnormality on those tests and did not. We've even tried some people where we think it's a high possibility on mitochondrial supplements without much success. So I think it's an area that deserves more study, again, especially for the people who are severely affected. But I don't think we're at a point now where we can be entirely certain that there is or is not a mitochondrial dysfunction. We just don't have the right science yet.
Excellent, excellent. Thank you. Certainly a lot more need to be done, not only on this front, but on all other fronts, from infection to neuroendocrine to other symptomologies and biology. Thank you so much, Dr. Rowe. We are so indebted to you, and this would be very useful, again, to the healthcare community and to our patients, and we look forward to seeing you soon, either on this platform or in a meeting or in our Research Advisory Council. Thank you so much for doing this, and I appreciate you helping us answer these questions that remain so that we can share them with the community.
Great. Happy to do that. Thank you.
Thank you so much. Bye-bye, everybody. So stay tuned to our next webinars. And again, like I said, we have Dr. Montoya and Dr. Sue Levine coming up on April 20th. So please stay connected with us, and we say goodbye to you now. Best to you all.